and I'm going to talk to you a little bit about ultrasound-guided brain tumor resection. I'm planning to talk quite slowly, but I'm going to get through the talk quickly, just so you can understand, and also to give an opportunity to the translator at the back to help you. So I'll skip a lot of my slides in the interest of time, but basically we know that brain tumors have been taken out for decades, many, many years. And what we have been revolutionizing over time is multiple things. Firstly, imaging, understanding what's happening inside this closed box. Okay. The next thing is, how do we take out whatever is inside that closed box that needs to come out? How can we do that safely? How can we take these brain tumors out safely? And so CT and MRI came around, and in fact, ultrasound came around very early, but we didn't utilize it for multiple reasons. The obvious reason was that you can't see through the skull. You can't see through bone. You can in pediatrics, in children you can, and in pediatric neurosurgery we use it a lot, but in adults you can't. So ultrasound, we started to use it in brain surgery very early, but because of the very poor imaging, not good pictures, most surgeons didn't use it. They didn't like it. And CT scan, MRI scan became very good, so we didn't need to look at the ultrasound. We put that to the side. But what's happened is that we now have MRI scan or navigation, MRI navigation or CT navigation is not very accurate. Once you start resecting a patient's brain tumor, that picture is no longer valid, okay? It's not a valid picture. And you can use an iMRI scanner, but of course an iMRI that Professor Drummond spoke about is very expensive, and you have to keep coming in and out, and it takes a lot of time. So that it's not a perfect option. Why is it important to have a good resection? Well, we know there's many papers now that, and most of you will know this who are trainees, that there are lots of reasons why it's very important to take out brain tumors as much as you can safely. So when you have a brain tumor, you try and take out all of it as much as you can in a safe manner, because we know that it improves life expectancy, improves disease-free survival, and these are graphs you've probably seen multiple times before. So let's get to the point. How do I do the brain tumor resections? Well, I have a setup like this in our hospital at the Royal Melbourne. I was very lucky because I was asking for one of these ultrasound machines for a long time, and then Professor Drummond raised some money from some people, and we bought one. So our hospital wouldn't buy us one either, probably the same as you, but we had to raise our own money to buy one. And there is an example of this at the back with the Brainlab stand, and I would invite you to go and have a look at it, please, during the break. These are the ultrasound probes that are specific for neurosurgery. So these probes, they look similar to the ones you see in obstetrics when they look at babies, but this is the size is a bit smaller, and the calibration of the probes is made to look at neural tissue very well. So how do you do it? The first thing you have to do is you have to put the patient in a position so that when you make the opening has to be on a flat surface like this. If you make the opening like this, then the water that you need to put between the brain and the probe is going to fall out. So it has to be a flat surface. And the next slide is a video, and Professor Drummond showed this earlier. You can see I am doing the ultrasound probe with my hand, and this is the picture we're seeing on the Brainlab computer. So how does it work? The ultrasound takes many slices, many slices, okay? That's what an ultrasound is. It's sound waves in a single slice, but the Brainlab takes all the many slices and brings it together to give you a 3D picture, okay? And then it puts the 3D picture on top of the MRI scan for the patient, so now you're having real-time imaging. And I'll explain that a little bit later on as well. What's the advantage of the intraoperative MRI? Well, it's much cheaper than the iMRI or intraoperative CT scanner. The space you need in the operating theater is much smaller. You don't need a big space for it. You can see very good images with high-grade tumors, low-grade tumors, and the time to use it is less than 1 minute. It's very quick. And we can demonstrate that later on if you're interested. So what are the advantages of intraoperative ultrasound? You don't need to be trained radiologically. You will learn as you do the job slowly. It's a very quick tool to use. You can use it very quickly. It's not as, tiresome as MRI. You have to go back inside and back and inside. You can see low-grade tumors and high-grade tumors very well. And you can keep checking. So for example, if you're doing a tumor resection, you're not sure if you've left some behind, you bring the ultrasound and within 30 seconds, you have a new image. You can see straight away what tumor you've left behind. It's very, very quick, okay? What is the disadvantages? Well, it's a learning curve. Most of you won't have been trained to look at scan what an image looks like for an ultrasound picture. So first time you see it, or first few times, you're not sure what you're looking at. But with time, your eye adapts. You start to understand what you're seeing. And I'll show you some pictures very quickly. And also there's the images, of course, the quality is not as good as the MRI scanner, but in some cases, it's actually almost better. And I'll show you what I mean. So what can we see? I'll go straight to the cases again in the interest of time. So this is a very simple case. And if you were going to use an an intraoperative ultrasound, the first thing you should do is use it for the very easy cases where you almost don't need it, but you're using it to train yourself to see what you're seeing and how to understand how it can help you with your resection. So this is a meningioma. Now the top image you can see there is the MRI scan. The bottom image is the ultrasound picture that I have taken before I open the dura. So this is on the dura. And you can very clearly see the meningioma, and you can see the falx there as well, right next to it, very clearly. Now look at where my marker is. My marker tells me that I'm on the falx, but really I am not on the falx. And that's because of two things. One, brain shift, but that's not going to account for all this. The second thing, most importantly, is inaccuracy of registration. So when we register a patient, you don't always get very accurate registration. But when you put the ultrasound on, that's a live image. That's the most accurate thing you have. Okay, that's a real image. So the bottom one is correct. And then what you can do is, of course, you can do the resection. You can do half the resection and check halfway, or you can just do the full resection and check at the end for any residual tumor, any tumor left behind. Now, as I showed you before, you can see the top image. The marker I have is not in the same place in real time. Now, the Brainlab machine can correct for that. And I'll just show you this very quickly. You can see here, this is the MRI, this is the ultrasound and MRI scan, and you can see the falx is separated by almost 1 centimeter there. And now what the computer will do is it will correct it. It will bring the MRI scan to match the ultrasound, because the ultrasound is the correct one. It's live image. It has to be correct. The MRI is off. So the computer has now corrected and so it's allowed for the shift and the registration area, and it's brought the MRI scanner back into where it should be. This is a new feature of the Brainlab machine. This is it showing it again. I won't go through it again, but you can see this is the tentorium. That the line, the U-shaped line, is the tentorium. And you can see a slightly thicker white line on the ultrasound, and it's much more than 1 centimeter away. And now the computer is going to correct that so that they are both aligned. So you got accurate, you have very accurate registration. So what does a high-grade glioma look like? Look at this picture. Most of us would resect or try to remove this tumor around where you can see the contrast enhancing image, correct? But actually, when I took this patient to the operating theater, this is the ultrasound image. Look at where the margin of the tumor is. It's much further away than where the contrast enhancing ring is. So my resection is going to be a little bit more accurate, or I'm going to be able to take more tumor by following this image, not the MRI scan image. And this is what it looks like on the computer. So the top one is just the MRI. The bottom one is the ultrasound. It's overlaid on the MRI scan. And the bottom one is after I thought I had a good resection. And you can see where the round circle is. This is residual tumor. This is tumor I've left behind. and I would have left that behind. So I went back in and I followed now I can navigate my resection to that bottom image. So it's not just a 2D image, I get an image and now I can navigate, I know exactly where that residual tumor is. And so you can see MRI, residual tumor, the tumor is now gone. Okay, so it's a very useful tool to help you try and get as much out as you can. I'll go through this one quite quickly as well. This is a low-grade glioma. So you can, I only wanted to show you this because high-grade gliomas show up very well for everything, including the 5-ALA. Low-grade gliomas don't, but with ultrasound, they show up very well. So you can see, and I'm sorry, I apologize, the lighting's not great, but you can actually, in fact, can we drop the lighting? I think that's probably the problem. But you can see the margins of the tumor really well on the ultrasound, and the computer has put it in the correct location to overlap the MRI scan. And there's my resection starting, so I can now do quality control as I'm resecting through to check how much of the tumor I'm removing. In this tumor, you can see that the tumor that spilled over into the ambient system, so I can now very carefully follow that tumor into the correct space without damaging the brainstem, because I can keep getting up-to-date images and I can know exactly where I am with millimeter accuracy because I keep updating my roadmap, which you can't do without IMRI on a normal navigated case. And you can see after the operation, we have a good resection, and you can see we followed that little bit of tumor medial to the brainstem there. And this is, I only want to show you this, it's another low-grade case, but I only want to show you this very quickly because you can see how well, look at the shape of the tumor. It's like it's a conical shape or upside pyramidal shape. And you can see it very well on the ultrasound scan. This is just a 2D image, but with a 3D sweep. And you can see what I've done there. If I just go back and forward, there's the tumor, there's half the tumor gone. You can see my resection is this part at the top, but you can see 3/4 of the tumor still left behind. And then now I've followed it all the way down in this funny shape. I can do that because I can navigate to my ultrasound image, and I can get a better resection with and a safer resection with this method. I've done that very quickly to try and speed up time. So in summary, and I can show you much more cases if you're interested. I have cases of metastases, as Professor Shashank spoke about. I have lots of other cases that I use it for. Vascular cases, you can see images of aneurysms very well. When you put the clip on the aneurysms, you can see if the blood is still flowing and whether you've clipped off the aneurysm. It has lots of really good uses. So it's a very useful tool in general for neurosurgery. It shows real-time imaging. That's what makes it special. So like I said, just to reiterate the point, with a normal navigated case, you're operating to an old image that is no longer updated. With this, you can keep updating your image and the computer will put it into the correct location for you on the brain lab so that you're navigating to millimeter accuracy through the case. Okay, it's better than obviously using navigation alone for that reason, because you allow for brain shift, you allow for resection, the registration error that I spoke to you about. It's a very quick tool. It's much cheaper to purchase one of these machines than it is to purchase an MRI scan, of course. You don't need to make any changes to the room. And Brainlab said if you buy one of them today, they'll take you all to Disneyland. But that's not true, no. And of course, with experience, with time, you will learn to look at these pictures and you will learn to understand what is residual tumor, what is tumor margin with brain. It's a really good tool for you. And I'll leave it at that. Thank you very much.